So Adithreya has got a lot of experience with the 3D system, particularly for training. So he'll talk about the 3D cataract surgery or 3D microscope.
Yeah. So I'm just going to briefly describe to you about the 3D microscope that we've implemented in our practice and the benefits that it does provide us. So perhaps you can consider this technology in your own center as well. So what exactly are the advantages that the 3D microscope gives you? It gives you an enhanced depth of perception, and also it shows you the ocular tissues in high definition format. So your maneuvers in the anterior chamber are much more precise and accurate. So this is the setup that we have at our operating center. As you can see here, the display is a 65-inch monitor, which is placed at a distance above 6 feet from the operating surgeon. And it's a heads-up display, so which means you don't have to look through the binoculars of the microscope anymore. You can be in a comfortable position and you can look 90 degrees straight at the monitor and operate at your own comfort. So again, the benefits are both to the surgeon and to the patient as well. The enhanced depth of field, it allows the surgeon to see more in one single plane of focus. So there's less need to keep changing your plane of focus during the process of surgery. All of the imaging is in 4K high definition, so which means you're able to see the tissues much more crisply. Your maneuvers are more confident and accurate. The benefit to the patient is the reduced light intensity. So we found with the 3D microscope, we can easily operate at an intensity of about 10 to 15% also, which enhances patient cooperation, especially when you're operating on topical anesthesia. So the biggest benefit we've seen is how it works as a teaching tool. So one of the hurdles that a beginner surgeon has is to overcome the understanding of spatial awareness and depth and awareness and space awareness as well. So the 3D visualization makes it effortless. They're easily able to understand the plane of focus and the plane of reference at which they're operating. So this is completely taken off the board, and young surgeons are benefiting from this very greatly. So this is a study that we did at a center when we compared the surgeon competency levels between 3D and traditional binocular microscopes. So we had 20 surgeons participate in this. Each of them were given 20 cases. All of them had a similar experience before starting. So each surgeon performed 10 surgeries on the 3D and 10 surgeries on the binocular microscope. And all of the steps were graded according to the ICO, Oscar phacoemulsification grading system. This has a grading from between 2 to 5, 2 being novice and 5 being competent. So this is a box and whisker graph which we see that in the 3D group, the competency scores were much higher in comparison to the 2D group. Now, when you dissect this further, let's look at the time taken for surgery. Time taken for surgery was lesser in the 3D group, and the competency scores were much higher in the 3D group as well. So let's dissect this even further. So this ICO-Oscar system grades it right from the patient draping right down to the closure of the wound. As we see here across the board on the 3D group, the competency scores were higher, and in comparison to the 2D group, the most significant step in the first initial steps of surgery was in the creation of the rexus, which means they were able to start the rexus and complete the rexus in a much more competent format. Again, when we go to the next few steps of surgery, when the surgeons were inserting the instruments into the eye, they were able to do so without any wound distortion and without the creation of any decimus detachment as well. Nuclear sculpting is another step in which the surgeons were able to perform much more easily. There were lesser passes being made to get the trench. The trench was done at the correct depth with the correct width. So they were able to crack it very easily. The other step, which was again very significant, the 3D was IA. Whatever cortical matter was left behind, they were able to go 360 degrees. They were able to tilt the IA probe with the mouth of the instrument to the correct area of the cortex under the rexus and able to finish the IA within a comparatively better time compared to the 2D counterparts. Again, in the spatial awareness is another key step. We saw a huge difference between the 2D and 3D group. Spatial awareness here is decided by how well the surgeon can manipulate the tissue. There was less incidence of wound distortion, less iatrogenic iris damage, and less damage to the corneal endothelium as well. So, to conclude on the study, the competency scores were higher in the 3D surgeries when compared to 2D. Time taken is significantly lower in 3D, and but what we did not see a difference is post-operative BCVA in the patients, and the rate of complications did not differ between the 2D and 3D group. So I conclude by saying young surgeons easily adapt to 3D visualization and benefit very greatly. So this is an video of the image guided system which can be implemented into the 3D system as well. So I'm not going to spend too much time on it. So again, and in case there is someone who does not want to use the 3D and they want to use the oculars, that is also possible. You can seamlessly transition between the 3D and the oculars in between surgery if you find any difficulty. So this is another issue that all of us face. 70% of ophthalmologists in India do complain of self-reported neck and back pain from hunching over and looking at the binoculars. Improved ergonomics is a huge benefit in the 3D surgery. One is able to easily look at the screen and operate at 90-degree angle, which is much more natural and gives you stress-free surgery. So the studies also will account for this. There are multiple publications which says that when you operate on the 3D, it's much more ergonomic and physiologically comfortable, relieves fatigue and musculoskeletal stress. But there are some limitations with this technology. One is that it has some doubtful implications for cornea-based procedures. It's very sensitive to any debris or opacity on the cornea. So if your patients have any corneal issues, it's probably better not to use it. There will be an initial disruption of workflow. If you're in a theater with two beds and you switch between patients, this may not be possible because this does occupy a lot of workspace. So you will have to move the beds out, or you'll have to do right eyes first and left eyes later. So that's how we do in our practice, but eventually you will adapt to it. Cost implications. Yeah, so this is a big thing. It's not a very cheap technology at all. And it is difficult to monetize in a private practice. You can't exactly charge patients more just for this technology. But this is a very good technology. If you're in a teaching institute, you will benefit greatly if you apply this into your practice. Thank you for your attention.